Hi everyone. I don't see anyone. Oh, here comes one more person. I'm going to go ahead and get us started. I'm Liz. I'm the chair of our Program Performance and Evaluation Committee. I'm calling us to order at 1:31. The first thing on our agenda is welcome and introduction, so welcome everyone. There are little microphones around the room, so I would ask that you speak up. There's a person that does our meeting minutes from the video, so it's helpful if you can use your teacher voice. So I'll start with our introductions. I already said I'm Liz, I'm the chair of the committee, and I'm a council member within LFUCG. I represent the 5th District, and I'll pass it to Bruce.
Thank you. I'm Bruce Davis, member of the HPI board.
Kitty Collins, Mountain Comprehensive Care.
Mark Brewer, Hope Center Street Outreach, housing caseworker.
Marty Jones, Community Action Council.
Billy Love, licensed clinical social worker at Life Stands.
Shannon Derrick, Passport by Melina.
Christina Ellison with New Beginnings Bluegrass.
David Chad with the Hope Center.
Paula Still, Director of Behavioral Health, Social Work, 3K Healthcare, and member of the board.
Jeff Herron, manager of LFUCG's Office of Homelessness Prevention and Intervention.
Diane Fleet, Greenhouse 17, chair of Homeless Prevention Board and Greenhouse 17.
Dustin.
I'm Dustin Malcolm, Hope Center Street Outreach.
Diane, did I get your seat? You usually sit by Jeff.
I like to sit by Jeff. Guys, you're good.
Okay.
I'll let you
Usually
share
it's
your
more important for
basket.
the board meeting so we can coordinate.
That's okay.
Because he can nudge me and go, it's a vote time.
Jamie, she texted me she's on her way, but we had to put David first anyway.
Okay, I just want to make sure they were still.
Yep.
Okay, the next thing on our agenda is our approval of our meeting minutes from our April 17th, 2024 meeting. Those meeting minutes are in your packet. Does anyone have any edits or suggestions for change? Okay, seeing no hands, I would take a motion to approve the minutes, and this can come from anyone within the COC. It's a full membership vote.
Jeff, can I get added to your mailing list?
Sure.
The packets go to Jackie, and sometimes she forgets to send them.
Gotcha. I will make sure.
So we have a motion from David. Do I have a second?
I'll second it.
Second from Bruce. All in favor for approval of the minutes say aye.
Aye.
Any opposed say nay. Okay, that passes. Thank you. We have the next items on our agenda are our program reviews. We have Bluegrass Care Navigators, their medical respite program, 2 programs from the Hope Center, and then the COC planning grant. Because of a timing thing, we were asked to move the Hope Center up in the agenda, so we're going to have the Hope Center go first on the men's emergency shelter, and then the street outreach program. Each presentation, for those who are new, has 10 minutes to present their information, and then we have time for questions with the group and discussion with the group. So I'll turn it over to you, David.
I'll pass these around if anybody needs them. It's 2 pages, so make sure to take 2. And if you don't need them, just give them back and I'll recycle them. So with the emergency shelter, we are funded through, I don't know, it's complicated, the ESR for lack of a need for a catch-all. But Hope Center Shelter, I think most of you know, so like I won't go too far in depth, but our goal is to provide basic emergency shelter, food, clothing, all of the basic necessities to men, 18 or over. We've been in operation since 1994, so this is our 30th anniversary of the emergency shelter, which is really kind of cool. And our basic process is the men come in to our emergency shelter through various means. Some of them walk in, some are referred by hospitals or other providers in the community, street outreach. We assess them through our intake office, do a basic kind of needs assessment and try to figure out what their needs are, or some of the issues, some of the barriers that they're having towards homelessness. And so many times that's employment, or it's substance use, it's mental health, and so we try to refer to programs that are based on some of those needs. So our goal is to get everybody who comes in into a program. That doesn't always happen. Of course, we do have a fair amount of people who are just coming in for night shelter, and that's okay too. But if people are going to stick around, we do like to get them working on something. So we provide assistance with applying for benefits, getting food stamps, SSI, SSDI insurance. We do housing assessments and referral to coordinated entry, and some of the pre-housing stuff like getting birth certificates or trying to get IDs. All of those things that become like a huge obstacle in terms of just the amount of time that it takes to do them. So we teach life skills, resume building, how to get jobs. We also have SOAR trained staff. Mark down here, it's our SOAR trained staff. We also do have some other SOAR trained staff as well. And we coordinate services for substance use, mental health, and a lot of what we do is connect to agencies in the community. So if it already exists out there, then we don't necessarily need to do it ourselves. We can refer out. We do have a health clinic that's located on site, so that is fantastic. And you can see here our number served last year was 1,361. That's pretty significant. That was, if I remember correctly, a little bit more than last year. And this does not include our winter shelter. Just, I think I put that somewhere in here, but that number is just those that are served in our emergency shelter. And you can see the age breakdown there. 18 to 24, we had around 7%, 25 to 34, 20%, 35 40 to 44, 23% on 45 to 54. So our age range, we have roughly 7% or so of 18 to 24 and 65 or older. The rest are all fairly equivalent there. You can see we're that doesn't look right. The race and ethnicity. Oh, there it is. I thought I left off white. I was like, weird. That's probably our largest group. It's definitely our largest group, so I didn't want to leave it off, but it is there. So you can see we are, our population is very low on the Hispanic population, but I've seen that over the last few months increase just incidentally. So I'll be curious to see how that weighs out next year. Many years ago, we had a very formal Hispanic program, and that our population used to be significantly larger, but since we've not had that, our population has declined. I didn't print the right one, so let me see. In terms of our outcome data, we had, of course, 100% of the households provided overnight shelter because that's what we are. And 80% are accessing case management services, and that does include our intake assessment. Many of the people that we come in, that's the only contact they have. Because you see our average and our length of stays for our leavers, 4 days, with the median being 1 day. It means the majority of people only stay there at night. And both of those numbers are significantly down from last year and the last couple of years. And I will say those are outliers because COVID really increased our length of stay. Even with those short-term stays, they tended to be around a week as opposed to a day or a couple of days. So our average length of stay did decrease this year over last year. The permanent housing destinations is terrible. I will say, I'll talk about that in a minute, but 3%, so 36 people, 3% is terrible. And 20% returning to homelessness. And so one of the things with the shelter that has always been an issue is exit data, figuring out where people go when they leave us. Because the majority of people are only staying a day. I don't know where they go when they leave us, and that's been constantly an issue. The other thing is that we have a lot of significantly long stayers. There's a big difference between 43 days and 1 day when you talk about your average lengths, and I think we have some long time stayers. People have been to the shelter more than a year, more than 2 years. And so we have made a lot of recent efforts to try to address that. We have a targeted group, we have a small group of caseworkers, myself, our intake coordinator, who are meeting and reviewing the cases of some of the people who have been long stayers. So we have a list of long stayers, and we're reviewing that and trying to connect those people one at a time, similar to the Eastern State meeting that we used to do with like the top 5 high utilizers. We've been doing that, and we've had some success with housing, thanks to Christina over here. I think we've housed many of those through New Beginnings, and we've had some good luck with housing some of those long-time stayers. And we've revamped some of our policies to try to encourage people to work on housing and try to incentivize that. And tried to become more of a housing-focused shelter. And I know that's something that we have been resistant to, but it's like painfully clear to me, and I think everybody on our staff, at least, that that's an area that we need to address. And from the time people enter, to go ahead and work on that housing plan. We can't have people come in with the expectation that they can live in our emergency shelter. So we are making a very strong effort to try to improve that, and I am very hopeful that those numbers go up. I can blame some of that on the housing market, but in truth, a lot of it is just on us. So in terms of ongoing evaluation, we look at the HMIS reports, we attend all of these meetings, coordinated entry. We again also have treatment team meetings every week to review some of the cases. And I'll talk about that in the next section too, but a lot of our resources this winter went into the winter shelter, and I think that had some impact on our services to our main shelter. We didn't have really a lot of time to plan that. We had 30 days to plan that, right, Jeff? So there wasn't a lot of ability to think forward with how we were going to handle that. So a lot of it was kind of flying by the seat of our pants, and I think that did impact our numbers overall. I think that's really it. Do you all have any questions or anything you want to know?
Mine's not necessarily a question, but just kind of a comment. The challenges that you face with the shelter data are not unique to you. Even at the Salvation Army, where there does tend to be a little bit longer length of stay, they still have those same struggles with people not informing them that they plan to exit or where they might be going to. We also saw that in the temporary shelter. We did in my office, some manipulation of data where even if somebody had individual one-night stays, if we looked across those, were we able to determine what a true length of stay would be, and even by manipulating the data, it was still relatively short, maybe 3 or 4 days for the majority of stayers at the winter shelter. And for me to try to locate our outcomes for that, I was looking not just at the shelter data, but I was running other reports and cross-referencing to see if those were people that were being housed in our housing programs, if they were appearing in our coordinated entry project. And some of the exit destination data came from those other sources because they weren't directly informing the shelter staff. So those are definitely some challenges that we face across the board.
And I will say, many years ago, probably 6 or 7 years ago, I was visiting with both the Louisville shelters and some of the shelters in Nashville. And like the Louisville shelters had an unusually high number of people that were housed. But it was just sort of data manipulation. They just assumed people exited to permanent housing. But the downside of that is that if they did not, then your returns to homelessness are going to be through the roof. And so if you have like an 80% return to homelessness rate, I think that's worse than having an unidentified number.
And also just if someone's still in a homeless situation, I would prefer to assume that and continue trying to engage them than assume that they're housed and no longer pursue services.
we've tried some different strategies with like exit books and things like that, but I think the nature of like overnight shelter is that they leave and don't necessarily have a plan when they leave in the morning. Just find a better place to go. I'm happy for it, but I wish I knew where they were.
David, do you have any rules at all that if somebody were to exit, that they can't come back for a certain period of time, or they're just able to come back? So they could stay at a friend's for a couple nights, and then that ended, they could come back to the Hope Center? Yeah,
absolutely. And we do have a lot of people who stay, 15 or 20 nights a month and stay elsewhere. We have a lot of people who come in and camp on nights that it's, the weather's better. So we don't have any rules in place for that. So they can stay wherever they want to.
Did you say your number of stayers has increased? I know the length of stay, but it's like more people that are, is it like the same group of people, like, or is this like a new, like, just over the years? I'm just curious, like, what are the characteristics of this staying group?
It tends to be people who, a lot of that population are people who have mental health issues, which is kind of predictable. But a fair amount of them have SSI. They have a lot. I will say, of the group of 20 or so people who are our longest stayers, most of them are going to fall in that 55 or older category, so they tend to be older. Most of them have Social Security, but they have trouble. They have histories that make it difficult to get housing, lots of eviction history. So they just all have complicated situations, and most of them, I think 75% have mental health issues that are at play there. And a lot of these people are popping up on coordinated entry, and we've tried housing, and that's not worked. They've not gone for the vouchers. I think I've referred the same person to New Beginnings maybe 3 or 4 times now. But, so that is a challenge, and that they tend to be like an almost predictable group of people that is hard to house.
You mentioned that the winter shelter impacted the emergency shelter. As you look towards this coming winter, what are kind of the lessons learned that you're thinking about?
They're hoping I don't ask them their
that's my big hope. I will say for whoever does it, like the data quality.
Okay, very nice.
It was a struggle to come up with a good system for gathering information. So like just basic data quality and collecting data and a good workflow. It took us probably 2 of the 4 months to get into a really good workflow. We had issues with like sign-in logs not matching, So there were like some very basic things that were just a product of not having a lot of planning time that I think would be better in the future. But I think also like the housing initiatives, we need to start those earlier and again work on that almost as soon as they come in.
Other questions or discussion points? I have one question. You mentioned the program that you had that was specific to the Hispanic population. Could you talk a little bit more about why that ended?
It was a funding thing. We had, I'm trying to remember, we had some funding through a church, and it was like a small amount of funding. It essentially funded a case manager, and we had, and their job was essentially connecting people to other resources. So they served as a liaison between the other programs. But they also worked with connecting some of the Hispanic clients with other resources in the community. So they worked a lot with, like Maxwell, or they worked with some of the other social service agencies that were working specifically with the Hispanic populations. And of course they were bilingual, which is a huge asset to have. Yeah. So it was funded. I think it was funded by like a group of churches, maybe like 2 or 3 churches, but it was just a position funding. Yeah, you're welcome.
Anything else? Okay, you have one more presentation on street outreach.
Yeah. Our street outreach project, we are in. This is the first year of this cycle of street outreach, but really it's not. We've been doing it a lot longer. So street outreach serves as, and Mark and Dustin are down there, and so if you have questions, they can chime in too. But our street outreach serves as the initial point of contact for unsheltered homeless individuals in Lexington. So we work with the community to identify those encampments, to reach out to those encampments and to provide connection with services. Our goal, of course, being either to get into emergency shelter or to provide whatever services we can while they're on the streets. Provide some ongoing case management. We're working with these individuals on finding housing, on connecting with other mainstream benefits and resources, SNAP benefits, SSI, insurance, the same things that we're getting in the shelter, but we're bringing that to them. They also work with Jeff's office and Parks and Rec and code enforcement and all of those groups to identify encampments and to carry out the city's SOPs for encampments. So posting those notices and working on housing plans with those individuals to try to get them to not only move along but also work on housing while they're doing it. And again, throughout the winter, I think our shelter was impacted by the winter weather shelter, but I think outreach was impacted more significantly because most of their job this winter ended up being in some variety of getting people to the winter shelter or trying to convince people to go to the winter shelter or working with the individuals who were in the winter shelter to connect with other resources. So when we look at the numbers, they were definitely impacted by what was going on there because they spent a lot of resources working with the winter shelter. And not all of those were captured in our street outreach numbers because not all of the clients that were there were street outreach clients when they went into the winter shelter. But they were really our only case management support that were Hope Center provided. We had a lot of community support, but for the kind of day-to-day stuff, they were our main source of case management. So we served 483 individuals and 438 households served. I wondered if I had like a dyslexic moment there, but I think that might be accurate because we did have some families, a small number of families that we serve relatively. 320 men, 155 women, and you can see the age ranges there. I think the race and ethnicity look pretty close to what we were seeing at the emergency shelter in terms of percentages. We dealt with 15 veterans, and 180 of those were chronically homeless. So, that's what, roughly a third. I'm bad at math, so if somebody is better at math, that's closer to a half, I think. I don't know. Somebody do math.
My calculator says 37%.
Somewhere
I was gonna say
between. Yeah, pretty good. So again, 483 unduplicated clients and 872 unduplicated contacts, which is a little. It's sometimes hard to. I will say just to kind of skip ahead. One of the drawbacks with the data collection here is that your unduplicated contacts assume that you've contacted a person. So a lot of what we're doing is responding to calls from police or code enforcement or Jeff and going to encampments, which is more time consuming than just like checking in with somebody in my office who's already at the shelter. So we spend a lot of time chasing people who aren't there. We were talking before we started about trying to contact a lady who's in an encampment here in town who just doesn't want any part of it. So we do a lot of that doesn't get reflected in the actual numbers. So 872 unduplicated contacts. 400 people on coordinated entry out of that 483. And I will say, I can't take credit for that. I don't really know a way to do that because some of those people, many of those people are referred by other agencies. So, but I went through and just pulled all the people that were on coordinated entry and matched them to the people that were on open street outreach clients. So that's roughly 82%. And I guess it doesn't matter who refers them as long as they're there. And the percent of new or increasing income is negligible. It's 0 for stayers and 2% for leavers. And for non-cash benefits, it is similar, 0 and 5%. So that number is very low, lower than the target. 63 out of these individuals are referred for intensive case management. That is 13%, again lower, which I think that number in particular is affected by the winter shelter. And I think we have seen, Mark can probably tell me, but I believe that's picked up quite a lot in the last 2 months or so. We've seen like a significant jump in that. And 25 or 39% of people who are placed in permanent housing of the group that was working with case management. I will say this also does not include the number of people placed in permanent housing. 26 were in shelters, 4 went to institutions, primarily sober living houses, and then 1 that was in a temporary housing situation. So those are all positive exits when you work with street outreach projects that aren't necessarily positive exits with other programs. There are currently 105 active clients. No, there are currently 100 active clients working with street outreach, and 105 of the clients that were working with outreach stayed at the Winter Village this year. So ongoing review includes reviewing monthly HMIS, biweekly meetings with Jeff, coordinated entry, and just reviewing the progress of these individuals and almost daily communication for the most part. Again, some of the issues that we had, we carried over a lot of clients from our previous project. And so since the winter shelter closed, we have made a concerted effort to go through and make sure that the people that are active are ones that we are currently working with. So anyone who's not been active for 90 days, we've gone through and closed. And so you see a large number of exits this quarter in particular, but that was really data cleanup that carried over from our previous project. And we are not through this year. This grant year goes through the end of July. And I obviously don't know how many days are in July.
31.
Yeah, I put 30, but it's okay. So we're not through this grant year yet, so I think we'll be a little bit closer to some of those goals. I think that's it. Any questions or anything on that?
David, when you traveled around before, when you were talking that you'd visited some places in the first report, I'm just surprised at the age demographics. I thought it would be a younger group. Is that sort of typical of other places that you've been when you went and visited Nashville and stuff, or are we an older street outreach group?
It was roughly similar, but I think Nashville in particular, like us, had a lot of youth 18 to 24 services, and so I think that affects the number of people that are showing up in the shelters in particular because they're getting services elsewhere. But also I think a lot of that goes into the homeless definitions because a lot of those youth are still in school. So I think that skews your data a little bit. But I do think we're a little bit older, and maybe I've not seen like Louisville's numbers recently. I've not looked at their point in time count, but I'd be curious to see like what their population looks like now. Because I've noticed coming into the shelter we're getting more of an older population. And I've kept statistics over the years on the age ranges, and the youth has ebbed and flowed over the last 10 years or so. The 65 or older has kind of gone up a little bit every year. 10, 12 years ago, we were getting like 2% over 65, and now we're around 7%. But the youth is a little more inconsistent, and I think that has a lot to do with what Arbor's doing and whether or not they're full. So I think that plays a role, especially being so close to us. I think obviously if people have that option, they're going to take it.
It's just such a difference in service delivery, isn't it? Like the
It is.
age of folks. So if a bulkier folks are 50 years old,
Yeah.
so different than if they're 23. I
It's
just
really
thought it
challenging.
would be a younger group, but
Yeah.
yeah.
This has been like a conversation nationally about like what trends that we're seeing. And I know that I've gotten contacts from like reporters with the Wall Street Journal that were trying to, see what we're seeing. So I actually have pulled our data before, and I got another request on this recently. And what's actually interesting is that even though we have like some providers that will have an experience of seeing an increase, system-wide, we really are not seeing a significant increase in the number of older persons presenting within our system. Some years it's even down slightly from the previous year. Like I think this current year is down a little bit from the year before. But we're not seeing overall a significant trend where there is an increase. The most recent year we would have fewer in terms of numbers and percentages that would be in those age groups, which I think is interesting because I know a lot of anecdotal evidence is that there is more older persons.
Yeah, it's interesting.
I wonder if it's similar to like what you were saying about the youth, that like there's a lot of more youth services. I wonder if we have more senior services now as the population
was
has
one of
grown,
the-
then there's more services for
One
them
of the
to
talking
help.
points for me was I think that a lot of those older persons are maybe accessing other services, like going to the senior center or interfacing with healthcare providers and getting support in other areas and maybe not presenting within our system.
Yeah, I know Christy, for our director of aging and disability services, that's like one of her focus areas is trying to like help people with housing when they need it. But I think she tries to be very proactive about it when she knows someone is like having trouble making their rent or a mortgage or something. She's really trying to get them resources before it becomes like a bigger problem. But I know she is very focused on that.
I think your older population is always more likely to access those resources just because they're more like aware of them and more engaged in other things. So it's probably a good.
And I think
Well,
some of them
it's a
are-
good thing to not see
Yeah.
it grow. So.
I think some people of a certain age are more likely also to find people who are willing to let them stay with them temporarily or things like that rather than enter a homeless shelter.
Other questions or discussion for street outreach?
And so when you were saying the ICM clients in permanent housing, like sober living doesn't count as permanent housing. So even though it wasn't permanent housing, that's still a pretty successful discharge plan.
Yeah, and I think even for our shelter, that is one that we have leaned on pretty heavily given the housing climate, because sober living houses are much more readily available than apartments. And, you're talking, $500 or $700 a month versus $10 or $1,000 or $1,100 a month, so.
Aren't
there's
those
a big
going to
difference.
be more regulated
Yeah.
come like July 1st?
July, yeah. But a lot of the ones that we deal with, we won't refer to ones that we consider shady. So a lot of the ones that we deal with are people that we will vouch for their quality. And many of them, to be honest, are alumni of our program, so we know very well, what we're referring to. And also who to call if there's a problem.
That makes sense.
Thank you, David. I know you might have to sneak out early,
Yeah.
so I appreciate you being here. And thank you too as well. Next on our agenda, we have the Bluegrass Care Navigators Medical Respite Program. Is that you?
Yes,
Hi,
that's
Jamie.
me. Hi.
Do you want to introduce yourself really quickly, and then you have 10 minutes to present, and then we can have discussion.
Sounds good. I'm Jamie Cody. I'm the Transitions Program Manager at Bluegrass Care Navigators. So we operate several transitional care programs, including the medical respite program. So we're one of only a few medical respite providers in Kentucky. And our model uses the national hotel model of medical respite. So it provides short-term hotel stays and supportive services to individuals who have post-acute needs. So generally these are individuals leaving the hospital, maybe, for example, have had heart surgery, have a drain, they're not able to, say, go to the Hope Center or another shelter, and just need a short-term time to recuperate and recover before returning to that setting or another housing setting. Or unfortunately, some that do choose to return to the street or settings such as that. So our goal is to, of course, promote optimal health outcomes and reduce those unnecessary rehospitalizations as well during the time that individuals are with us. We serve Fayette County. We have accept referrals 24/7. And most of our referrals come from hospital settings or shelters or other homeless service providers. So in addition to a short-term hotel stay, we have case management services that include provisions for food, shelter, food, transportation, coordinating with individuals' healthcare providers, making sure they get back to their follow-up appointments, as well as any mental or behavioral health services as well. So we do some clinical assessments during that time, assessing their health literacy, ADLs, depression, anxiety, other assessments that help guide our interventions. And then individuals have access to support line 24/7 for after-hours needs. So the last calendar year, we served 110 individuals, 81 households. Almost 11% of those were veterans. As far as demographics go, we had 39% that were at least 55 years or older. Average length of stay was 8 days. All of our participants had a stay of less than 30 days, so it is a very short-term medical respite model. In some other areas, you'll hear of medical respite models that are brick and mortar facilities, and those may have a longer length of stay, on average 30 to 45 days. So in general, participants are with us for a shorter length of stay. So to look at discharge disposition, we have 67% of our population, patients served, discharged to an emergency shelter such as the Hope Center, Catholic Action Center, Salvation Army. We did have 8% or 9 patients that declined shelter, discharged either to their car or street. So that's certainly a population that we focus on, and outcomes that we look at to try to see, what can we do differently, or were there any other potential options or interventions we could have done to help support housing. We had 6% that went to temporary or permanent housing, generally with family or friends, and then 2% that went to permanent housing via a rental. 4% self-paid a hotel stay after their medical respite stay ended, and we had 5% that went to a sober living or other substance use treatment facility. We did have 5% that went back to either a hospital or medical or psychiatric facility. So that was because some of those needed long-term care placement, and we're transitioning to that. Some inpatient psych treatment. For instance, we had one with who returned to methamphetamine use and had some suicidal ideations, but did follow the plan that we had put in place called 911 and got into the hospital. So in that instance, certainly was the level of care that he needed to receive treatment. And then we had 2 individuals who left the program early, and both of those individuals had damaged the hotel room and were not able to return to the hotel setting. So in those cases, we do try to work with those individuals to get them somewhere to another setting, but those 2 did leave the program early. And then one of the outcomes we focus on is our readmission rate, which is something we look at across our programs as far as rehospitalization. On average, we serve a very high-risk population of individuals, transitioning them in our other programs to home or other settings, and our average readmission rate for that population is 10 to 13%. So when we looked at specifically medical respite, Less than 6% had a hospital readmission, and less than 2% of those were considered avoidable readmissions. So some of those were planned surgeries or care that they needed. So when we talk about housing as healthcare, it's really unique to us to see such a low readmission rate in this population when we would expect them to be on the higher, closer to 20%. So that's always good to see. We did have, like I said, the 2%. Two participants that were unable to return due to the property damage. 96.4% of our individuals in medical respite completed their medical respite stay and their treatment plan. So when we look at challenges, I think when we receive referrals, and this is, I know, challenges that are not unique to our program, but individuals who have chronic medical conditions. Maybe they have an amputation or some significant physical mobility limitations and they're not able to access existing shelters or other settings, but they don't have any acute medical respite needs. So that's, we do try to connect those with other resources and have been successful in doing that. We have some great relationships with local hospitals and insurance partners as well. So we actually have a couple of RNs and a social worker embedded like at UK Healthcare. So we're able to go to those patients' rooms, see them in person, assess them for eligibility. And there's been times when individuals have been referred and they really don't have an acute medical respite need. For instance, one they said, well, he's not allowed to go to the shelters. And we're like, well, let us check. And we checked, I think it was with the Hope Center, and they're like, no, he's not banned, he can go. And so we're like to the hospital case manager, no, he can go to the shelter and there's really no need for him. So great, they were able to transition, to a less restrictive environment. So that is great to be able to kind of assess that and have access to their medical records and really know holistically what's going on with the patient and be able to collaborate both with the medical side and the social service side as well. Of course, housing assistance needs, some with no income or, some that need more accessible housing, first floor apartments, wheelchair ramps, or maybe need some additional care in the home. So those are all barriers that we continue to face. And then coexisting behavioral health and substance use needs, which I think is not, again, unique to our population, but we've really put some intentional focus on that and making sure individuals, for instance, with substance use get connected to those resources or peer support, medication treatment for opioid use disorder, whatever it may be, or sober living. And then as we look at ongoing evaluation and improvement, one of the things we do is routinely review the National Institute for Medical Respite Care's best practices, so making sure that we have incorporated those best practices into our programming and updating policies and procedures as needed. Continuing to look at our outcomes, like I said, really focusing on those that return to the street or that leave the program early, and are there other interventions or resources out there? We do maintain an internal resource directory that we're continually adding to and connecting patients with. And then we also have regular meetings with our hospital partners, and we partner specifically with Anthem Medicaid and Aetna Medicaid and transitional care, so we're able to meet with them monthly. So if we do have any mutual patients that are in medical respite, to really help get some additional case management services or services through their Medicaid MCO when that's applicable as well. So I'll pause there. I think that's all I have, so happy to answer any questions.
Questions or discussion, comments?
I always do. Do you want me to ask? Did
Yeah,
you have
go
a
ahead.
question? Okay.
And I'll-
You go. I'm thinking still about mine.
Okay. I was thinking that only individuals could access medical respite and that they weren't able to come with a partner or a spouse. But then I was looking at your individual versus household numbers, which were different. So I just was curious on a clarification.
Sure, great question. Yes, we do want families to stay together. We do want an individual, if they have an established caregiver or spouse, significant other, family, we do want to keep them together. So usually during intake, we'll assess that and ask, so who generally, how do you manage your your daily activities? Who's in the household? Who helps you? Because individuals do have to be able to maintain themselves independently in the hotel setting and provide for their needs, or have a caregiver that's established that's willing to help them. And when we say established, it's just because sometimes we will get someone and they're like, oh, and I have 2 friends and they're going to come with me and they help me, and when that may not be the case. So we do want to make sure that they're either part of their care or part of their household or family unit.
That's wonderful.
Yeah.
We've done that for both the medical respite program and for the program we did over the winter for our elderly and disabled. Operated the same way. We had a lot of households served in both.
Yeah.
One, just Jamie saved us during COVID, so her whole group like just bow down to you always. So it was phenomenal. It kept Greenhouse 17 from to be able to stay open. The work that you all did. So thank you. I might have missed because I was looking at my notes when you first started talking. So primarily, who are the main focus of folks that are the best clients for you? So we're apt to get calls from like a hospital, someone's being discharged, and there's always that balance of, are they needing home health to come in? Is congregate living the best for them right now because they might be medically fragile? We don't have any medical assistance at Greenhouse, so if they need like wound care or even just kind of basic, getting dressed and mobility of, getting to the bathroom and things. Do you help coordinate any of that, or is that a little bit beyond your scope too?
Yeah. No, we start assessing when we get the referral, planning for discharge then, because sometimes what we will find is we'll get a referral and it's someone who may have been in the hospital for 4 months. Cannot find placement anywhere for this individual. They have a lot of medical complexities. There's no facility willing to take this patient. They're in a wheelchair. And so a 1 or 2 week medical respite stay is just going to prolong that. And then the expectation, I guess, is that we are going to push them to the curb in the wheelchair. And obviously that is not a safe discharge or a patient that we would feel like that's the appropriate setting for. So and it's hard to say no to those because we want to help everybody, but we want to make sure that they're appropriate. So in that, we're looking at individuals who it is a short term, obviously for funding reasons and other reasons we don't have the ability to keep someone, say, for 3 months in the program. So that is a short-term medical need. We do coordinate with things like home health to make sure that they have those services in place, or if they need to go to the wound care center, we can provide transportation for them to go there 3 days a week, make sure they get to their medical appointments, help facilitate, medical supplies, or we can provide things like Depends or Chucks or Medi-Sets, things like that, make sure they have their medications. So all of that we're doing. We don't do the actual hands-on care. So say they needed daily dressing changes, we would need to either coordinate with home health or wound care, or they would need to have a caregiver. We can certainly provide a lot of education and support, make sure they have their supplies, but make sure that someone's able to physically do that care while they're in the setting.
I was thinking it might be something worthwhile to talk to down the road, because sometimes we would be able to take them at Greenhouse 17 if we had that coordination set up, I just don't know that we've implemented enough or know the contacts enough to get that going. And so we usually say you can come in after, but the services could actually happen at Greenhouse 17. We just might need your guidance on how to get that going,
Yeah. Happy to talk through that and what that might look like, or how we might be able to support.
Glad to be a part of that conversation to see if it's something that we would have opportunities to replicate across our system. I think we would have to zero in on what each facility is able to do with their space and staffing and everything, but I think it could be a viable strategy, because unfortunately a lot of times when I'm contacted by like our hospitals, essentially what we're really looking for is like nursing home level of care, and oftentimes it's even expressed to me that there's a particular barrier to getting that person into a nursing home. And so the frustration seems to be directed towards the emergency shelter, but I truly understand that when an emergency shelter has limited staff and 100, 200 clients, they can't necessarily help someone toilet if they're not able to do it independently. So we do see some really complex challenges.
And one thing I'll add too is, and I'm not sure, I've not looked at it in the last couple of months, but DMS had, I think, an amendment for the 1115C waiver to actually look at funding potential medical respite. So they're looking at funding brick and mortar style. So obviously we don't have that type of setting. I mean, there could be an opportunity for partnership or something like that, but that is something that Medicaid is exploring, potentially funding for Medicaid recipients a short-term medical respite stay. It's not been approved, but there are conversations about that. So that would be great, and I think would be able to help more individuals and across settings.
Right. Interesting.
Yeah, would love to see that happen.
And not so much a question, just as a comment, since we recently went through the ESR process, I had shared some information with our committee just so they could kind of understand some of the things that we were able to see through our HMIS system that might not be just clear from someone's narratives. You all do such a tremendous job. I know we had great outcomes with the winter program, but also looking at medical respite. Obviously you had a significant amount of positive outcomes for such a short-term program. But not only did you have like a decent rate of individuals exit to permanent housing, very few of them returned. When we looked for returns, we would be looking at kind of 2 years back and then who had exited to permanent housing and then re-entered. And you all only had a 5% return rate. Considering the short length of time that you have people and some of the challenges that they face, I think that is, you guys are clearly making discharge plans with a lot of care and understanding that they're going to something that's sustainable.
Well, that's great to see. Yeah, I wasn't aware of that. And we try to start that. I think this speaks to the benefit too of having the great collaboration. I think over the years too have grown because you all are familiar faces. When a few years ago you wouldn't be, but just wonderful service providers that we have, and just able to connect and collaborate, and the hospital partnerships being able to be embedded into their or access their EMR and really see holistically from the medical and social standpoint really helps us when we have that information. Don't always, and that's okay, but it is nice.
Other questions or comments?
I wish we had a psychiatric motel respite program. Sure. Could someone make one of those?
Sometimes it leans toward that. I mean,
I noticed that was one of your challenges.
yeah, and that's really something we've focused on is, everyone who is experiencing homelessness has experienced trauma. That is trauma in and of itself, and many have coexisting mental health conditions, substance use disorder. So really, we started having interdisciplinary team meetings and really making that a focus of, okay, are they connected to a mental health provider? If not, have we offered that service and offered transportation to that service and get them connected, whether it's telehealth or in person? Not everyone wants to, but just making sure that that's a focus that we're proactively addressing, because yeah, it's huge. Really
increasing. I'm sure you've seen more, probably co-occurring that
Mm-hmm.
over the years.
Anything else? Okay, thank you, Jamie.
Thank you.
Our last item for program review on the agenda is the COC planning grant.
So I'll be presenting on that. Marissa is traveling today, so bear with me. This would be our annual funding that we receive through the Continuum of Care competition to help with cost of planning and system coordination. So we are reporting out on the recently completed calendar year of 2023. So we just started a new grant year in January. Right now, we are still operating with about $62,000 of funding, and we'll talk about that again in a moment. So this funding serves primarily to cover Marissa's salary, and as well as a few other costs that we have. So we've used this to help also with things like lived experience engagement activities, like providing incentives for people that participate in our planning processes. But the bulk of it is going to be for salary. What that position is responsible for is working with the board and membership and carrying out our requirements to HUD through the COC program. So that's going to be things like developing and carrying out our annual competition for funding, monitoring and establishing our performance targets, directing policies for our coordinated entry system, ensuring compliance with other requirements such as our annual point in time count, just general ongoing evaluation efforts and system planning, Some of the accomplishments that we've had as a result of this funding. Obviously, we took over as the HMIS lead several years ago and have really been able to significantly increase our level of HMIS participation, which contributes to increased bed coverage, which is a factor that we are assessed on for funding each year. But we've also made significant strides in terms of data quality. On some of our individual fields, we've seen, it's not uncommon to see things like double-digit improvements in terms of reducing error rates. So that's been something that's been really helpful, not just in terms of getting data into our system, but making sure that it's reliable data that we can actually use for system planning. Other things that we have done has been to implement some quarterly meetings with KHC as our HMIS implementation is statewide, and been able to maintain good consistency at the state level to help us really see things that is activity that goes across the 3 different COCs. We have been able to really increase the level of technical assistance provided for things like HMIS as well as compliance to regulations. And we had specifically done some things around redesigning our data dashboard. We have managed to complete and implement an ongoing annual evaluation calendar for written program standards for different program component types. Within this year specifically, we offered 16 different new user trainings, 27 technical assistance sessions for users and agencies. We have a end user webinar that is every other month that usually is going to focus on subjects like if there's a particular data set that we're working on, reviewing with our end users how the data they input directly correlates to those system performance measures or data sets, and helping anticipate data challenges and be proactive in addressing them. Those are recorded, so they're also available to end users who can't attend live. And then we put a lot of efforts into improving our process around the annual COC competition. That involves having some positive outcomes in terms of our application itself. We received a 10% increase in funding in the last COC round. That includes nearly doubling the amount of money that we're going to receive for our planning grant. We're going to be going to about $118,000 from the 62 that we're currently at. So that will help to offset some of the cost of our HMIS position and help us to do some more activities with persons with lived experience. Lived experience engagement has been one of our major focuses. We had really made a concentrated effort with that around the time of the special NOFO that was for addressing unsheltered homelessness. While we did not get funded for that, it did really help us to test the waters in terms of how to go about trying to reach individuals and really engage them in meaningful ways and getting input and being a part of our processes. We held a really successful, it's in this year, not the previous year that we just are reporting out on, but we had a really successful session at the library about 2 weeks ago. We had probably about 30 individuals, and we had a really good conversation about our proposed new assessment tool for coordinated entry. We got some useful feedback, and had some folks who were really engaged. Like if another participant was off topic, they would be like, well, that's not what they're asking this. So we're starting to also identify some folks that we can help to maybe bring into a higher level of participation within our system. We also, as mentioned, have been working on developing a new assessment tool to replace the VI SPDAT, and so there's been a lot of significant work in the previous year as well as the current year that went into that. Some of the outcomes, there's not established national metrics for a planning grant, so these are all kind of just mirroring what we accomplished last year with what we have done this year. We managed to increase the number of users that went into our HMIS system. We had 35 new users last calendar year. We also increased the overall number of trainings and technical assistance options. We have now successfully been doing our VASH imports that bring our veterans data from their system into HMIS. We've been doing that for about a year and a half now. And this position also, again, coordinates that point in time count. We had a record of 266 volunteers for our point in time count. Some of the other things that Marissa wanted me to try to touch on with you all. So a couple areas that we wanted to solicit some input. One was around things like the HMIS end user work groups. I know we might have at least a handful of people that participate in those. Marissa wanted to solicit if there's anybody that had ideals for how we might use that end user work group moving forward beyond what we're currently doing. Additionally, soliciting some information around things that we can continue to do with our efforts to increase the transparency and ease of the annual COC competition. If there's any kinds of activities that we might be able to engage in that help people feel like it's easier to understand that process, or that might better prepare them for the competition. I know we're trying to do some of those things already, but we would gladly welcome any input. I'll also take general questions.
You got anything?
No, I know. Thank you for looking at me. I don't.
I feel like our numbers have dwindled.
There's a lot of accomplishments in here, so I want to say thank you and applaud you for that, for everything that you and Marissa have been doing.
Well, this one specifically is a lot, Marissa.
Yeah. I'll tell her when I see her next, but or maybe I'll make a note of that for my report out for the committee, but it just seems like there's a lot of progress being made, and attention to detail, and I think meeting some of the, I don't know, like concerns or things that have been brought up in the past, I see it being directly addressed. So I appreciate that.
Well, thank you. I'm extremely lucky to have Marissa, and she's really fit well into this office and really picked up, before this position, she had worked with the Human Rights Commission, so she was familiar with housing, but not necessarily in the same way that we are. So it's a sharp learning curve, and she definitely stepped up, and we work really well together, which I think has allowed us to, if one of us has a kind of an issue where we're not able to complete something, we can kind of just, without even saying anything, step in and help the other person out. And I think that's allowed us to make that progress and to follow up on things and kind of keep some ongoing conversations. And even if we're not able to tackle something at the moment, we keep it on our radar and look for those opportunities to meet two goals at one time, or if we have downtime, know where that effort needs to go.
And Marissa makes all those pretty graphs.
Yes.
Can you speak a little bit more about the end user group and what that is?
Yeah, so we have in the past had different forms of this, but it's essentially a group that's targeted at those that are directly our HMIS users that are inputting data into the system. So, for example, HUD will do an HMIS data standards update, a major one probably every 5 years, and then once every 1 to 2 years a more minor update. And so even once you train somebody to get into the system, you have to make sure that you really keep their knowledge current. There's going to be different fields that are required, or there might be different ways that HUD is viewing a certain data point that we might need to really shift the focus, or we might see something in our data sets where we realize that, users aren't updating the approximate date that someone's homelessness started when they enroll in a program, so it's pulling that date from a previous enrollment. And if that person hasn't been active in our system for a really long time, what that does is greatly skew their length of time homeless within our SPMs. And so we have to make sure people know about that and are looking and updating that as people go through, so that we get more accurate measures of how long people are experiencing homelessness. And it's those small things that are difficult to communicate necessarily every time that you see it in the system. So having a platform where we can get the most of our users together at one time, we can really work on improving how we are approaching our data just by having that platform.
Is that, you said something you already do, is have an end user group? Or, okay.
Yeah, we've been doing it. I did a variation of it when I was in Marissa's role, and then we have kind of played around with some different formats. I originally started as in person, then we went to Zoom. We tried every month, we've tried quarterly, we've kind of settled on every other month. It's frequent enough that we're able to meet all those different HUD things that happen throughout the year, but kind of reduces a little bit the number of meetings that people have. And obviously there's been a huge increase in the use of things like Zoom during the last couple of years, which has really made it more flexible to where we can offer recordings of those very easily without having to go through a lot of significant steps on our end. But that way, if a case manager who also is an HMIS user has a crisis that comes up, they don't just miss that opportunity. They still have ways that they can get that information.
So what kind of feedback were you looking for as far as that meeting then? I'm sorry.
So one thing is for anybody that is participating in those meetings, if there's any suggestions, like we try to identify the topics that are timely or that we think are relevant, but if there's anything that sometimes an end user will tell us, I really struggle in working with entering household data. Or if there's a particular data field that they don't really understand exactly what HUD is looking for, we're glad to take any kind of input as to what we might focus on for future sessions.
Gotcha. Okay.
Because we don't enter directly into HMS, this might not be the right thing, but one thing we've been working on internally, but it seems like it's always an issue when I'm looking at Marissa's beautiful graphs, is change of income. So I don't know, is that an HMIS data entry issue of it not being updated as people are going along, or is that something different?
So it can be. It can be two things. It can be true performance that's being reflected, that measure, or it can just be our data collection and entry. What we oftentimes find is that we get so busy with the case management that we don't always stop and go in and do either an annual assessment or periodic updates just as people report income changes. And it's really important to get those into the system because you'll oftentimes see the language levers and stayers in these presentations. And when it comes to income, the only ways that we can really capture that is for stayers, it's looking at when they entered the program and then their annual assessment. And for leavers, it's looking at entry and exit. And so if we don't capture those changes as they happen, or if we don't complete someone's annual assessment, which is probably the most common factor impacting what we see in those measures, we're really not capturing the good work that might be going into helping participants increase their income.
One of the things we're going to start doing internally, so again, it's a little bit different, but when a person exits Greenhouse 17, and we usually kind of know when folks are exiting, so it's a little bit different than I think Salvation Army or Hope Center. Like, there's usually a plan. We usually know where they're going. So when we exit, we're going to kind of tag ourselves to kind of go back to the direct advocate because they usually know if there's been an income change. And I think they've just not changed it as they've gone through our program. So it's just another catch-all, I think, or not a catch-all, what's that called? Checks and balance. To kind of make sure we're going back to it.
And this is actually a great conversation for us to have because as we know, you all will be directly taking on a COC program this calendar year. So it might just be helpful for our teams. I know they've already been having some meetings, but to specifically think about what are some of the challenges that our HMIS users have so they can proactively kind of coach you guys on some of the things that will impact those measures.
That'd be great.
And then another thing is we've been doing reports on our coordinated entry system and data and systems integration. That has focused on things like the number of referrals, number of persons that moved into housing, some of the demographic data. Marissa was also wanting to know if there's anything else that people would like to see out of those coordinated entry reports that we can be investigating. Right.
As I said, before we move on, I just a comment of, just want to say that I greatly appreciate where you all have started doing like the data quality review much prior to COC competition time. I know that's a lot of extra work and time on your all's office, but it is very, very helpful to be looking at it a little earlier in the year and not scrambling at the end. So I greatly appreciate you all for that.
Make the efforts to continue that in future rounds. For those that maybe don't go through that process, a lot of our scoring criteria for the annual COC competition HUD requires us for our community to score well. We have to place so much emphasis on performance measures and data versus just like narratives that people can write. And so when we pull HMIS data, it's some of these things that we're talking about right now. Sometimes there's something where something just doesn't get entered correctly, but also sometimes maybe there's something that's not correct about that report. Maybe there's a defect to where it's pulling the wrong data or not pulling it correctly, and that can skew the performance measure. And so we learned that sometimes with these issues, if we don't actively look at that information in advance, there's really no opportunity for us to investigate with our providers if there's something like a defect or just a small step that they can take to correct an issue, and we have to just score them based on what we're seeing. So we've started already in the past couple of weeks doing that review for this year's competition, knowing it's right down the pike. If there is something that can be resolved that more accurately reflects a provider's performance, we want to make sure we can do that and give them credit for the good work they're doing and not penalize them for something kind of outside of their control. Any other questions about this program?
I inquired of our data entry person who attends the HMIS work groups, and she didn't have any feedback. She said it's all good. No, so
Good.
go.
Okay, that was our last program review on our agenda today. Does anybody have any other public comments that they would like to make for the group or announcements?
I'll just say, remember, we don't meet next week. We had to bump this meeting up a week because of Juneteenth. So I know we're in the habit of a certain kind of schedule. We won't be meeting next week.
And to that point, August 21st is our next meeting at 1:30 at this location. And on that schedule, we have Arbor Youth Services, Lexington Rescue Mission, Mountain Comp Care, and Beginnings for different program reviews. So, not seeing any other comments or hands or frantic waving, I will adjourn us for today. So thank you everyone for being here.
Thank you.